Hi everyone, this is Professor Welch. Today we're going to talk about gross motor function and balance. So these are on one presentation, but I am going to make two separate videos for them because they are listed as two separate assignments for you to watch for your lecture. So I will pause, so then you'll have to go back and rewatch the balance video. Just a little heads up about that. But these are two core areas of physical function that are especially relevant in recreation therapy. Understanding these areas are really going to help us in designing the interventions to promote the independence, to prevent falls for participants, and to encourage participation in meaningful activities. So let's go ahead and dive in. So what is gross motor function? So gross motor function refers to movements involving the large muscle groups. So as you can see, walking, standing, sitting, lifting, we're going to think about these as the basic blocks of mobility, and they directly influence someone's ability to participate in everyday activities and recreation. So in therapeutic recreation, we often assess functional independence, fall risk, and participation in recreation. So for example, somebody recovering from a hip replacement may need support with transfers and gait training before they can safely return to their favorite leisure activities. So some common conditions that you may or may not be familiar with all of these that could affect motor functioning are Parkinson's disease, which often causes tremors and postural instability, stroke, which can lead to weakness or paralysis on one side of the body, multiple sclerosis, or we can also call it MS, can cause fatigue and poor coordination, spinal cord injuries, which affect trunk control and mobility, and orthopedic injuries such as hip or knee replacements. Those may also temporarily limit movement for a person. So as recreation therapists, we don't treat the medical condition itself. That's obviously doctors, but we do design the activities and programs that can improve movement, promote independence, and support overall quality of life. So that is our main function as recreation therapists, working with those who have gross motor disabilities. So next we're going to dive into neuroskeletal and movement-related functions. So when we're looking at joint mobility, we're going to say that that is the ICF B710 to B729. This functions of the range and ease of movement of a joint. We're going to look at the flexibility or range of motion, or you might see it abbreviated as ROM. So active ROM, a patient is performing without assistance. So that means that the client can move the joint independently. With active assistive ROM, the client moves the joint, but with some assistance from the therapist. And with passive range of motion, the therapist or equipment moves the joint completely. So that might be physically putting hands on a patient or using some sort of other mechanism in order to help them to move that particular joint that you are using. So these are just some examples of different degrees of flexion. So this has the mobility of the joint with the hip. So we can see this is all in degrees. So hip flexion, bending is 0 to 125 degrees. Hip extension, straightening is going to be 115 to 0 degrees. Hip hyperextension, which is straightening beyond the normal range, 0 to 15. Hip abduction, which is, your leg moving out and away. And again, these diagrams have a pretty good snapshot of what that looks like. Moving away at 0 to 45 degrees. Hip adduction, you're moving towards the central axis of the body, 45 to 0 degrees. And that hip lateral rotation is going to be the rotation away from the center of the body at 0 to 45 degrees. Hip medial rotation is towards the body at 0 to 45 degrees. Knee flexion is at 0 to 130, and knee extension is at 120 to 0. So those are just some numbers, like I said, and this provides a pretty good example of the different movements of the knee and hip that we can look at. And then this is just further showing us our range of motion. So full flexion to full extension and what that's going to look like for us. So we can just keep in mind that example that normal hip flexion is about 0 to 125 degrees and abduction is about 0 to 45. So these numbers are really going to help us establish that baseline for tracking progress of our patient. So a goniometer is an instrument that's used to measure range of motion. That's a hard word for me to say for some reason. It's commonly used in physical therapy. I can say that I personally have never used one in practice, but I have seen physical therapists that I work with use one. The inner degrees is going to indicate the flexion, and the outer degrees is going to indicate the extension. So there's two sides, a black and a red side. So the black is for larger joints, knee, elbow, and hip, and the red is for smaller joints, the ankle and wrist. So basically how it works, you're going to align the fulcrum of the device. And again, if you want to see any videos or know more how this uses in action, there's a lot of good YouTube videos and other things out there to show you how to use this better. But so you're going to align the fulcrum of the device with the fulcrum of the joint to be measured. You're going to align the stationary arm of the device with the limb being measured. You'll hold the arms in place while the joint is moved throughout its range of motion of the device. And then you'll read the degrees indicated by the arrow line of the movable arm. And the inner degrees are going to be your flexion, and your outer degrees are going to be the extension. So again, if you want some more info on that, you can go ahead and find a video, and that will show you better how to use it. Like I said, I personally have never used it, but I have seen it used in practice. So these are just some more pictures demonstrating what that looks like. We have our little L, the extension, all of our different things that we could be measuring. So another example is a sit and reach test. This can assess hamstring and lower back flexibility. It's widely used, but it has limitations because arm, leg, and trunk length can influence scores. So just something to keep in mind. I don't know if y'all remember doing this in elementary school. I definitely do. I was actually just talking about this the other day and how I used to have to do the sit and reach for the presidential physical fitness test. So, but that is another test you can use. I have not seen this used in practice, but I'm sure that there are some facilities that you might encounter that do use it. So measurement of activities and participation. So looking at physical activities, so that's any bodily movement produced by skeletal muscles that results in energy expenditure. So types of physical activity that can be related to recreation therapy or exercise, recreation, and therapy. So exercise is that structured purposeful physical activity to improve or maintain fitness. We are kind of defining recreation as enjoyable, voluntary physical activity for leisure or social interaction. And then therapy is going to be typically prescribed by physical activity aimed at achieving specific clinical outcomes. So why might we measure physical activity? So obviously it's important to us because we want, a lot of times, especially if we have a patient who's sedentary or doesn't get out too much, it's really important for us to be making sure that they're active and engaged. So we measure activity to identify baseline levels and detect inactivity. We want to set individualized goals for therapy, And we also want to track progress and adherence to their plans and what their plans are post, discharge from wherever they are, and to evaluate the effectiveness of interventions. So we look at the level and intensity of the activity. So that's how we're going to measure it. So it's level, the frequency is how often does somebody exercise, and the duration is how long are they active each time. So when we're writing our goal or our objective, that's what we're going to make sure that we're putting in there. So it's the level and, the frequency and duration of what we're doing. So again, physical activity intensity, this, we just discussed, but that's what you're going to want to put in your objective. So frequency, how often does one participate in physical activity, and the duration of how long does one participate. So here's an example right here. So patient number 1 increases frequency of participation from 2 times a week to 3 times a week. And then another one, patient number 2, increases duration of exercise participation from 90 minutes a week to 120 minutes per week. So we also have a variety of different assessments for physical activity. So these are some things that we might use as physical activity monitors to kind of get a better snapshot. As we can see, eyewear, we have smart garments, headbands, skin patches, smart watches. One that I think I've seen frequently used is a pedometer. So this is really a low-cost basic device that measures how many steps you take. There's an accelerometer, measures movement through orientation and acceleration and force. So these are other things that we can put on our participants, and they can measure, depending upon what you're looking at, a variety of things that are listed on the side. So from heart rate to sweat analysis to sleep, all of that are things that we can use to help gauge our activities for our participants. So another tool that we can use is BMI. So BMI is important because it's a useful indicator of overweight and obesity. It helps assess the risk for chronic diseases associated with excess body fat. And there obviously are a lot of health risks associated with a higher BMI, like cardiovascular disease, type 2 diabetes, gallbladder disease, respiratory issues, and certain cancers. So just being aware of what the BMI is and keeping that in line as well is another thing that you can look at, especially if they do have an underlying condition like one of the ones listed above. And as you may or may not know, there is a lot of criticism to BMI and how it's used. So it may overestimate body fat in athletes. So as we all know, muscle weighs more than fat. So sometimes it's not always 100% accurate measurement of, the BMI of a particular person. And it may also underestimate the body fat in older persons who have lost muscle. So again, that goes back to that whole muscle weighs more than fat situation. I personally am not a fan of BMI. I have not really seen it used in practice that often either. So just something to keep in mind. It might not always be the best measurement. You can also look at METs, which is metabolic equivalent. So 1 MET equals energy expanded at rest by an average adult. This is going to represent the baseline from comparing activity intensity. And it's also going to help to quantify energy expenditure across individuals and activities. So why might we use METs and RT? I'm so sorry, I'm having trouble with words today. Why might we use METs and RT? So it's a standardized measure for assessing physical activity intensity, which a standardized measure is always that's always something being standardized is the most beneficial in practice. It's useful for tracking and predicting a person's activity level, and it also allows comparison across individuals regardless of weight, which is how it differs from BMI. So this is in my opinion, a better measurement to use in rec therapy. So some important considerations: MET values are estimates and can vary based on a variety of different factors. So that can either be body composition, their physical fitness, cardiovascular health, environmental factors, like temperature and altitude, things like that. So this is just a little diagram of at-home activities versus sports and leisure, kind of showing us how many METs are expended doing each of those things. So physical activity questionnaires that we might have included in either an initial assessment or once we get to know the participant, how physically active are you survey. There's a Yale physical activity questionnaire. There's a vigorous physical activity at work questionnaire, global physical activity questionnaire, and CHAMPS. This requires recall, obviously, for the participant from a specific period of time that you want to measure. So there can be some criticism related to these types of physical activity questionnaires as well. So looking at CHAMPS, this is an activities questionnaire for older adults. This assesses weekly frequency and duration of various physical activities typically undertaken by older adults. CHAMPS measure may be useful for evaluating the effectiveness of programs aimed at increasing levels of physical activity in older adults. So this might be useful if you're trying to start a new exercise program or want to incorporate a more rigorous exercise program, like incorporating weights or something like that into a program, just to kind of maintain a measurement over time. And like we mentioned in the last few lectures talking about evidence-based practice, this is a really good way if you did want to measure that frequency and duration of physical activity over time for older adults and why it's important. So something to keep in mind. So this questionnaire is about activities that you've done in the past 4 weeks. So this is an example of what that looks like. So you can take a snapshot of that. And this is just a further example of that CHAMPS assessment, so what it might look like. And then this also lists the scoring of the CHAMPS. So typically any assessment that you are using that is like this is going to have how you would score it in the back. So scoring, and then you just go through, add up your numbers, and then that's, what you get. And normally, again, like as you can see, there's a lot of detailed instructions on how you would score something like this. And that brings us to balance, which is going to be our next topic in this lecture. Again, I'm going to pause this video, and balance will be uploaded as a separate video and play pause it. So I will see you all soon. Thanks for listening.